and we are heading into the last couple of sessions. It is my great pleasure and honor to welcome and introduce Professor Laurent Brochard, and we are extremely, indebted to Dr. Brochard for making this entire symposium possible. It is only with his blessings and with his great support that this entire program has been possible. Thank you very much, sir. And I hope we have future programs also all over the world. And this we are celebrating as the first International Mechanical Ventilation Day. And I hope 14 June becomes some kind of a mechanical ventilation day internationally, and greater collaborations and greater celebrations and greater events can take place on this day. We already have a sepsis day, we have a ARDS day. Let's hope we can have a mechanical ventilation day. So thank you, Professor Laurent Brochard, sir. Grateful and indebted to you. So, sir is intensivist and clinician scientist at St. Michael's Hospital, Unity Health Toronto, and was division director of critical care, University of Toronto, for 10 years from 2014 to 2025. He holds the Keenan Chair in critical care and acute respiratory failure. He has been editor-in-chief of Intensive Care Medicine Journal. He is currently deputy editor of the American Journal of Respiratory and Critical Care Medicine, which we call the Blue Journal. He created a research network on mechanical ventilation, REVA. He leads an international group on respiratory physiology, PLUG, and this particular symposium is being endorsed by the PLUG group. And he leads the Center of Excellence in Mechanical Ventilation in Toronto. He has mentored and directed numerous trainees, many being leaders in critical care all over the world today. He has published over 750 peer-reviewed research papers and has an H index of 133, which is, I think, very, very high, as all of you must know. Thank you, sir, and we are really honored to have you with us and to listen to you for your talk today.
Okay, thank you very much. Let me re-share my... Okay, thank you very much, Tapesh, and I'm really glad to see that this symposium is a real success. And I'm very pleased to have this meeting, this session, which may overlap a little bit with what you heard before, but I think it's really important for clinical practice. So I'm going to discuss about Peep titration. I put a photo of Brian Kavanagh and Luciano Gattinoni. These two persons were really giants in the field and unfortunately passed away. Brian I was working with him in Toronto, and I knew Luciano for many years, and they both contributed a lot to these topics. So I wanted to put their face here. So my laboratory has been working with a number of companies listed here for research grants or equipment. And I'm going to discuss about PEEP and especially PEEP in ARDS or hypoxemic respiratory failure with the goal of recruiting the lung. And I know it's not always intuitive to understand what means lung recruitment, because it should be very clearly differentiated from just an increase in lung volume, which can be obtained without recruitment anytime you increase PEEP. So this is a nice illustration where at the top you have different photographs of a lung which is out of the chest, which is initially collapsed. And you see from left to right the inflation of the lung progressively, and you have below the pressure at which the lung progressively reopen. And you see before 8 or 12 centimeters of water, only very small parts of the lungs are open. And then the lungs start to reopen. And during the deflation, when you decrease the pressure, what's really interesting is to see that obviously for the same pressure in the system, you have much more lung volume during deflation than inflation. And this is the principle of recruiting the lung, right? Reopening regions which are not open before And this is why people have tried to make a recruitment maneuver, for instance, which unfortunately have other side effects. But the principle was to get more volume for the same pressure in the system. And the lower part of this slide is showing the same relationship, exactly the same lung, but in the form of a volume pressure loop, something you can do on a ventilator, where you put the pressure on the x-axis and the volume on the y-axis. And again, if you just measure the pressure volume loop, to recruit the lung, what you would like is to get more volume in the system for the same pressure. So remember this concept, because this is something we are going to discuss again. How can we be sure that we have more volume in the system for a given pressure? So I put this slide, which is a study done by Jose Dianti, and was a nice systematic review and network meta-analysis of all the trials which try to see whether a low PEEP versus a high PEEP could be better for patients with ARDS. And obviously, it's a bit complicated. What the network meta-analysis allow is to compare different arms, which may not have been tested one against the other, but through different trials. And you see on the left part of the slide, you have the studies which use a lower PEEP arm, so that's all the studies. But it was compared sometimes with high PEEP and prolonged lung recruitment maneuver, or high PEEP with brief lung recruitment maneuver, or higher PEEP without lung recruitment maneuver, or higher PEEP based on esophageal pressure. So a lot of different comparison. And at the end, you see on the right the table which show the kind of recommendations which could be made, and the certainty of evidence. So it seems from this study that, let's say, with relatively moderate to high certainty, we can say that probably higher PEEP without lung recruitment maneuver are more effective than lower PEEP. And then when you look at every other comparison, the level of certainty still remains moderate. And so the conclusion say it's probably more effective or probably harmful, but there is nothing really certain. And I'm showing that because it reflects a little bit the confusion in the literature, where there have been different recommendations. If you look at different guidelines about high PEEP, the American Thoracic Society is suggesting that high PEEP may be more beneficial in hypoxemic respiratory failure, moderate or severe, whereas the European Society is less clear on that. However, there is a kind of consensus in these guidelines about avoiding especially prolonged lung recruitment maneuver, which may be more harmful than beneficial. So what can we make of that? I think the number one conclusion is that there is no recipe for everybody, and you need to individualize the PEEP titration and PEEP settings in the patient. So doing that, and these are questions which have almost never been asked in the trials, so you need to remember that when you want to interpret the studies. I think practically at the bedside, you have two questions. First, is my patient, or let's say the lung of my patients, recruitable? So if yes, it means it's worth to try to reopen the lung. If not, we should not attempt to reopen the lung, because we will create more harm than benefit. And the second question, which is separate from the first, is if the lung is recruitable, how can I titrate PEEP? So I'd like to show you a number of techniques which can be used to address one or the other questions. But I think for you, it's really important to think about these two questions separately when you use the ventilator in your patients. So is my patient recruitable? There have been suggestion to first use oxygenation, and I would say in the same category, imaging and compliance, which means very basically and simply that the sickest is the patient, the higher the chance of this patient being recruitable. I know it's obvious, but keep in mind that if the patient has a very good oxygenation, it's probably that there is very little to recruit. Okay, so less recruitability is also associated with less severe lungs. But of course, it's not very precise. But if the oxygenation is really low, you may think of really trying to recruit the lung and using higher Peep. I put BMI because BMI, so the body mass index, reflecting the process of obesity, overweight or obesity, is not exactly about the lung. It's about the chest wall and the abdomen. And why is it important? Because if the lung is compressed by a high pressure generated by the chest wall and the abdomen, high PEEP may be needed to counteract this pressure. And then there are specific tools. CT scan, I don't think is possible at the bedside. PV curves and hysteresis are interesting, but a little bit complicated to do. And we designed a specific tool which is called the recruitment-to-inflation ratio, which is measured with airway closure, which I will describe in a minute. The second question is how to titrate PEEP if my patient is recruitable. And as you know, people have proposed to use oxygenation, especially with the PEEP FiO2 tables. I'm not saying it's completely unrelated, but I will show you examples where PEEP and oxygenation can really be divergent, and that oxygenation is not a very good marker. The other way to titrate PEEP could be compliance. However, you need to be aware of the many limitations of using one value of compliance for the whole lung, and that's a big limitation. Another way to titrate PEEP is to use the express trial approach, which just simply propose to increase the PEEP until you reach the plateau pressure limit, maybe of 28 centimeters of water, for instance. It has the advantage of being very simple. But the two techniques which probably in the modern area are most attractive are electrical impedance tomography for those who have this technique available, and esophageal pressure, and I will discuss these two quickly. So I'm going back to a bit of history. The first really very influential paper in the field of ARDS was from Peter Suter and Barry Fairley in 1975, so that's a long time ago. And the principle of the study is very simple. They took patients with ARDS and they studied different levels of PEEP. And you see the middle is what they call the best PEEP. And they went from -6 plus -3 plus 3 plus 6. And the first result, which I think we should remember today, is that there is no real threshold or limit in terms of oxygenation. Usually, the higher you go with your PEEP, the higher you go with your PaO2. And why is that a problem? Because you miss the fact that you may have a better oxygenation, but a worse hemodynamics, and a decrease in cardiac output will decrease what we call the oxygen transport, which is the product of the content in oxygen by the cardiac output. In other terms, your oxygenation looks better, but you are doing worse for the patient because you are delivering less oxygen to the tissue. So definitely, oxygen can go with recruitment, but can also go with other mechanisms which have nothing to do with recruitment. And one of the reasons was shown relatively early, which is, if you look at the title, is that the fact of depression of cardiac output is a mechanism of shunt reduction in ARDS. And you see a graph showing the individual values of shunt and cardiac output in every patient. And on the right, you have the shunt cardiac output relationship. Remember, shunt is the proportion of the cardiac output which goes to the non-aerated part of the lung. And interestingly, if you increase the cardiac output, you increase shunt. You have more zones of the lung non-aerated which are now perfused. This is why, for instance, in ECMO, you need to have a very high cardiac output going into the ECMO system. Otherwise, you will increase shunt and be not being able to oxygenate. So remember, decreasing cardiac output makes your PO2 looks better. So that's really a problem. And therefore, Suter and Fairley say we need to find something else to determine that we are at the best PEEP. And in this paper, they propose that compliance could be a way to distinguish where you're optimal in terms of mechanics and also in terms of what's best for the lung. And that's very smart and very interesting. They also found dead space was also in this zone. If you look carefully, you see that, well, the difference between, for instance, best PEEP and +3 may be difficult to detect at the bedside. And in fact, the same group a few years later show that the best PEEP in terms of compliance depends very much on the tidal volume you use. For instance, that was a period where the tidal volume was not limited, so they tested from 5 to 20 ml per kilogram. And I just highlighted in yellow 10 milliliter per kilogram or 7 milliliter per kilogram, which are very close to what we use now. And you see the 7 milliliter per kilogram, the compliance curve is almost flat, which means in practice, you cannot distinguish with compliance whether the best PEEP is 6 or is 15. So that's a limitation with compliance. But I would say the most important limitation, and I'm going to show you an example, but it varies depending on the lung severity, is that it's one parameter for a very heterogeneous lung. Okay, this is an experimental PEEP study we did with Bush and Katira and Brian Kavanagh. And on the left, you have the pressure-volume relationship during a decremental PEEP trial from 20 to 3. And the top curve is the compliance of the whole respiratory system. And you see that the best compliance seems to be for a PEEP of 15 or 16. But using this technique, which is called the electrical impedance tomography, we could separate the two parts of the lung as illustrated on the CT scan. The dependent part, which is mostly the one where you have non-aeration, and the non-dependent one where you mostly have aeration. So the non-dependent one may be more at risk of distension, whereas the dependent one may be more at risk of staying collapsed. And you see now we have the two curves for the non-dependent and the dependent part. And for the dependent part, the best PEEP is around 15, so very much aligned with the global curve. But for the non-dependent part, which is the one more at risk of distension, you see the best PEEP is around 6 to 8 centimeters of water. So very, very different. And there's no question that you can find one single level of PEEP and therefore one single level of compliance, which will indicate an optimal threshold for the whole lung. And here the non-dependent part has less weight on the compliance than the dependent part, but it may vary depending on patients. So that's another big limitation of using compliance. And if you want additional, let's say, demonstration, you probably heard of this study, the ART trial, which tried to use a very high PEEP to get the best compliance using a decremental PEEP trial, and they did not find a benefit. They even found that there was harm associated with very high PEEP. But remember, all these trials, no one asked before randomizing whether the patient is recruitable or not. So, because I think it's a big gap, we worked hard to try to design a technique, and I'm going to show this technique with some details because it can be used on any ventilator. You don't need a special ventilator or a special device. And in my sense, it can help to distinguish whether the lung is more recruitable or not. We call it the recruitment-to-inflation ratio. It's a very simple maneuver, and it's based on not the CT scan, which is too difficult to do at the bedside, but the pressure volume curve technique, which, if you remember, I illustrated with the first slide from the experimental study. Before that, I have to tell you that we realized that in patients with ARDS, not all of them, but a certain percentage, there is a phenomenon which has not been described until recently, which is airway closure. So I'm not talking of lung collapse, I'm talking of airway closure. For instance, if you think of the large airways, that could be in the large airways like the trachea or the large bronchi, the airway can close before you reach FRC. And this is illustrated here by these pressure volume curves. With on the left, you have a patient with no airway closure. So you see as soon as you insufflate, pressure volume, again, the same kind of curve I showed you before, you immediately start to increase the volume. But in this other case on the right, you see that the initial part, there is almost no increase in volume. And then we realize that this increase in volume is not volume going into the lung, it's just the circuit of the ventilator. So it's like pushing against an occluded airway until you reach a certain pressure at which you reopen the lung, and we call that the airway opening pressure. And these are examples of two other patients you see where every time you have you need to reach a certain level of pressure. We just look at pressure above 5 centimeters of water, but there are many patients where it's lower and it doesn't matter because your PEEP will be higher than that. And this phenomenon exists in maybe 1/3, 30% of patients with ARDS. And I think it's really important to recognize because your minimal PEEP should be set at the airway opening pressure. Okay, so this is the way you can do it. On the ventilator, you use a low flow inflation. So you set the ventilator with very low flow. And when you see an abrupt increase followed by a different slope, this means that you have airway closure. This is an example which we published to patients who needed ECMO. And you see the airway opening pressure was almost 20 centimeters of water, which means until you reach 20, nothing is entering into the lung. There are in fact two techniques. So the technique I described with the low flow PV curve, but there is also a technique described by this group where you can compare the initial pressure increase to the pressure drop at the time of a plateau. And when it's very different, it suggests that you have airway opening pressure. If you want to know better about it, go to our webpage, which is free, which was really designed by Thomas Pireno, a very smart respiratory therapist. and you will find several videos explaining how to do this maneuver. So the next step, when you know whether your patient has or does not have airway opening pressure, is to do the recruitment to inflation ratio maneuver. So it's illustrated here. It's a single breath method. So you start from a high PEEP, and we suggest that this high PEEP should be by default 15 centimeters of water. You first reduce the respiratory rate to be sure there is no autopit. That's really very important. And then you drop the PEEP in one breath from 15 to 5. So your delta PEEP is 10. And then you record the expired tidal volume. I will show you an example. And this expired tidal volume is the volume in the system trapped by PEEP, which is a mixture of the normal inflation of the baby lung plus the lung which has been recruited and which is de-recruited in one breath. Okay, so that's a kind of zoom on the maneuver itself. It takes less than 1 minute. I'm going to show you in real life. And you see the delta PEEP of 10. You see the exhaled volume from which you separate the predicted exhaled volume based on compliance and the excess of exhaled volume, which is what has been recruited by a PEEP of 15. So again, from the same website, rtmaven.com, I'm going to show you in real life the maneuver and how you can use the data with the calculator in rtmaven.com.
For this calculator, you need to use the set tidal volume, and you need to observe exhale volume during the maneuver, as well as plateau pressure, which can be measured in real time by using a short inspiratory pause, like 0.2 seconds. Reduce the respiratory rate to 8 breaths per minute to ensure there is no auto PEEP.
Okay, you reduce the rate. That's really very important to be sure there is no auto PEEP.
Prepare for a PEEP drop of 10 centimeters of water. In this example, we're going from 15 down to 5. At the end of this breath, observe the exhale tidal volume, 398, and then keep watching for the exhaled release volume, which is 818. Also, look at the plateau pressure and enter all of these values into the calculator as instructed. Return back to your previous settings.
Okay, so this is the maneuver in real time. And I can tell you it's really simple. You need to train a little bit, but we do that all the time in our patients on assist control at the early phase when they are deeply sedated, because you need the patient to be sedated. And with the calculator, you will get a ratio. The ratio, we call it the recruitment to inflation ratio. And the higher the ratio, the more recruitable is the lung. So for now, we are not completely sure, but we think the threshold above which you can think your lung is recruitable is 0.5, and below 0.5, it's probably useless to try to recruit the lung. Just showing you that there have been a number of validations. This is showing that it has some correlation with oxygenation. It is correlated with the decrease in dead space, which I think is really interesting. It has been correlated with lung ultrasound, correlated with EIT. It's not very strongly correlated with CT scan because they measure different things. But just to say, it's probably an interesting technique, very simple, which gives you a direction. If the lung is not recruitable, low R to I ratio, don't try to increase the PEEP. Keep the minimum PEEP to get oxygenation reasonable. It may be a PEEP of 8 or 10. However, if the lung is recruitable, you have a high recruitment to inflation ratio, then it's worth to try to increase the PEEP. I'm not going to say put a high PEEP in everybody, but try to increase the PEEP and look at other variables. I wanted to show you that because this is an interesting kind of validation of the R to I ratio. You know that the risk of higher PEEP is to increase pulmonary vascular resistance. And in this very nice study done by Xavier Monet and his group, they measured pulmonary vascular resistance at low PEEP and high PEEP. And they compared the effect in patients who were high recruiters based on the recruitment-to-inflation ratio and patients who were low recruiters. And you see that when you have a low recruiter, increasing PEEP, distend the lung and increase pulmonary vascular resistance. When the patient is highly recruitable, you have much less effect, and you see here no change in pulmonary vascular resistance. So it's a nice validation from the cardiovascular standpoint of a technique which tells you which patient you should try to recruit. So I would say if my patient is recruitable is the first question. If no, use the minimal acceptable PEEP, and for instance, it could be the airway opening pressure if you have airway closure. But if yes, you should try to increase PEEP. One solution is the EXPRESS study. As I told you, you increase PEEP until you reach a plateau pressure limit, or check driving pressure, hemodynamics, PCO2, knowing that driving pressure, like compliance, has a number of limitations. Or, and I will show you some data, you can use an additional technique if it's available in your center, like electrical impedance tomography or esophageal pressure to measure transpulmonary pressure. So just a word about electrical impedance tomography. I know it's not available everywhere. I hope it will be more and more available because now a number of ventilator companies are incorporating that into their ventilator. It's a technique where it gives you an image of the lung like a CT scan image, but it shows the functional ventilation. So where does the ventilation go? How much goes? And so you see, for instance, for the same patient, the comparison, you cannot say why is that missing here, because it could be either an effusion, a consolidation, or a pneumothorax, but you see that it's not going into this part of the lung. And the immense advantage is that it's a bedside technique, which gives you images in real time. So you can monitor the patients while you are doing changes on your ventilator or positioning the patient, for instance. And the technique which has been the most interesting, I think, is what we call the crossing point approach, because from the lung contour, you can divide the lung into multiple pixels. And for each pixel, you can evaluate the change in impedance, which is the change in volume, compared to the change in pressure you set on the ventilator. So, which means you can get the compliance of every single pixel. And you can say, well, for this PEEP level, this is a number of pixels which are distended. This is the number of pixels which are collapsed. And see, for instance, on the left, a patient have a decremental PEEP trial from 25 to 5. And you see in purple the distension curve, and in red the collapse. And you see in these patients, it's nicely the two curves cross, because when you go below 15, you stop to have hyperdistension, but you start to have a lot of collapse. So in this patient, you would say, well, the best PEEP, the best compromise between collapse and distension is obviously 15. And in these other patients, you mostly see distension until you reach a low PEEP level, and it's a reverse for collapse. So the optimal crossing point, indicating the best compromise between distension and collapse, would be 7 centimeters of water. And just to give you an example, this is a study we did during the pandemic. It was a multi-center study. And for instance, we had all kinds of recruitability in our patients with COVID-19, patients with low recruitability, medium recruitability, high recruitability. And you see the average of the distension curve and the collapse curve for the three groups. And if you take the crossing point, what's really remarkable is that it will give you different PEEP values, of course, around 8 to 10 for the low recruitable, around 12 to 14 for the medium recruitable, and around 16 for the high recruitable. But every time you choose a crossing point, you know that your collapse and your distension is less than 10%. And because we don't know what's the most risky for the patient, I think that's a very reasonable and interesting compromise. And you see that individual comparison in our study with the best compliance, maybe you could say it's not so different, but in some patients it's higher, some patients it's lower. So it's slightly different. The last technique I'd like to very briefly mention is the esophageal pressure. When you put a balloon in the esophagus, it measures the pressure locally. And locally means it's the same pressure than in the pleural space at this level. What do I mean by at this level? I mean that in the chest, in fact, you don't have one pleural pressure, you have a gradient. And the gradient is in part related to the weight of the lung. So the pleural pressure is much higher in the dependent part than in the non-dependent part. And the esophageal pressure will reflect more the dependent part. So what people have said is that, well, maybe we can use this pressure to adjust the PEEP to get a transpulmonary pressure, which would be the difference between the esophageal pressure and the airway pressure, around 0. And this technique was proposed by Danny Talmor and his group in Boston. And you see this nice tracing, airway pressure at the top, esophageal pressure in the middle, and transpulmonary pressure at the bottom. And I'm showing that because now there are at least 3 or 4 ventilators which can display this kind of curve. And you see they adjusted the PEEP around 16 because the end expiratory esophageal pressure was around 14. So they get a transpulmonary pressure around 2 centimeters of water. We don't have the definitive evidence this technique is best for patients because there was a randomized trial by Jeremy Beitler, which did not show evidence. However, they found that for some subgroup, there may be a benefit of this approach of esophageal pressure guided PEEP. And they recommended that the difference between airway and esophageal pressure should not be more than 2 centimeters of water. My sense is that this technique is really very well suited for finding the good pressure to counteract the effect of the abdomen and the chest wall. And therefore, there may be a big difference if you have obese patients or non-obese patients. This is an observational study we did with Lu Chen from several centers. And we just look at the outcome of patients who had the PEEP set with an expiratory, a positive and expiratory transpulmonary pressure or a negative one. And you see there was no difference in outcome in the non-obese patients. However, in the obese patients, and we are not the only one showing that, there was a huge possible benefit of this high PEEP, meaning having a non-negative and expiratory transpulmonary pressure in obese patients, and just starting at a BMI of 30. So my feeling now is that this technique is very good for obese patients because you may discover that you need much higher PEEP than what you thought, and it is usually very well tolerated in these patients. The last thing I'd like to show you is that in my title, I say it can be good both for the lung and the cardiovascular system. This is a series of studies, experimental studies, where we did PEEP titration, decremental PEEP trials. So you see the PEEP at the bottom from 0 to 20. And what we look at was the pulmonary arterial pressure. And we also did, in some animals, the pulmonary vascular resistance. And we found, and this is 2 models of lung injury, and we found this classical U-shaped relationship between pulmonary circulation and lung volume. But whereas in physiology, the optimal lung volume is FRC, here it's not anymore FRC. It seems to be very much the optimal combination of collapse and overdistension as indicated by the EIT. And you see with the two models, the transpiratory pressure was not very far, or the compliance. So I do think that both for the lung and the circulation, you need to find an optimal PEEP level. And again, looking at hemodynamics at the bedside when you titrate PEEP is very important. So, in conclusion, there cannot be a unique optimal PEEP for all regions of the lung, so you need to find a compromise. I think that knowing the overall recruitability, is there potential for recruitment, is the first important step. Insufficient PEEP can have very serious negative on the right ventricle. It's well known for excessive PEEP, but it's the same for insufficient PEEP. And if the technique is available, EIT may offer an optimal compromise for PEEP titration. Thank you very much. I will stop there and be happy to address any questions.
Thank you very much, Professor Brochard, sir. You touching upon one of the most important concepts, how to set peak, and of course the concept of recruitment-inflation ratio, which has come from your lab, so to say. Yes, I request the audience or viewers, if you have any questions, please put them up, and sir will be happy to answer them. So maybe, sir, I can just, while we are waiting for the questions, you mentioned about hysteresis. So how do we understand hysteresis, sir?
Yeah, so the hysteresis is what I showed on my first slide, where you have a difference between the inflation curve and the deflation curve. Experimentally, it was shown that this is related to the fact that you have a liquid air interface in the lung. So if you wish, like it can stay closed at the beginning of insufflation. You need to reopen, and then you will have a different behavior of the lung. So this is a normal phenomenon because of this air-liquid interface. And of course, this is very related to recruitment also. It exists in physiology, but it exists also in when you have lung injury. And so the idea is that maybe finding the PEEP which will minimize this hysteresis could be a good solution. But you need to do the whole pressure volume loop, and that may be a bit complicated, a bit long. And there are methods to calculate an hysteresis ratio and which to minimize it. I think it's the same concept. It's a little bit more demanding in terms of measurements, but it can be done also on many ventilators at the bedside. You just need to have a XY screen able to show the pressure volume loop.
Thank you for the answer, sir. So this is a question, should we look at compliance and SCVO2 simultaneously while selecting PEEP?
That's a good question, because I think it refers to the hemodynamic part of PEEP, and I think in theory it's good. In practice, it would mean that you need to be sure. I mean, ideally, it should be really the central venous gas, which is obtained with the pulmonary arterial catheter, but usually we don't have it, so we take the central venous pressure, oxygen saturation, which may not be as optimal. And it would mean to make repeated gas measurements, and you need the patient very stable. So in theory, it's not a bad idea. In practice, it's not super easy to do. But I would suggest that looking more at SVCO2 may be useful, because you may sometimes understand that what you think is good for the patient because your SaO2 is better may not be good for the oxygen delivery because you worsen your oxygen saturation delivery.
Yeah, thank you, sir, for the answer. Then the next question is from Dr. Ricardo. He says, since prone position ventilation is sometimes also considered a recruitment maneuver, should we check recruitment to inflation ratio prior to proning?
Well, that's also an interesting question. So, one thing I didn't show is that in our experimental study, I showed that the optimal PEEP for the dependent lung and for the non-dependent lung were very different because it's one part of the lung which is not very poorly recruitable and the other one which is very highly recruitable. So you get with the overall compliance, you get a mix of the two. And I'm saying that because when we did in the same experiments the prone position, we found that the difference between dependent and non-dependent became very small. It was almost the same optimal PEEP for dependent and non-dependent. So during prone position, you have much less risk with your PEEP because you may have very little difference between dependent and non-dependent. That being said, there have been a number of studies which show that the recruitment to inflation ratio could change after prone positioning because it has been acting as a recruitment maneuver. And I think it would be interesting to do. I'm not sure how you would change your management based on that, but definitely, well, it would change your management if your recruitment to inflation change after the prone positioning, for instance. But definitely, it can change after prone positioning, so it's a good idea to remeasure it.
Thank you for the answer, sir. Then another question, why the closing volume is more than the opening lung volume for the same pressure? Is it because of the sigmoid shape of the hysteresis curve or some other reason?
So it's another reason, which is the again, remember, it's a closing volume of the airway, so the airway close. This is a natural phenomenon. When we try to exhale, we cannot empty our lung because there is a lung volume at which the airway close, and it's called the residual volume. And it is well known that with age and in some disease, the residual volume can become very close to FRC. Well, in those patients, it seems that it's like the residual volume is higher than FRC, so the equilibrium volume. And I think there may be many reasons for that. One big reason could be the chest wall and the abdomen again. To give you an example, we found in some patients that it was very difficult to do a prone or it was impossible. And we tried to put sandbags on the chest. And what we found is that by increasing the weight of the chest by these sandbags, we markedly worsen airway closure. So I think the chest wall and the abdomen play a role in airway closure. And that's why you will find airway closure at relatively high levels much more frequently in obese patients than in non-obese patients. So we don't know, but sometimes it can be relatively central airway closure because of the chest wall.
So, any other questions, dear viewers? So I think, sir, there are no more questions. Thank you very, very much, sir. We are really grateful to you for making this symposium possible. Thank you, sir.
Thank you very much, Tapesh. See you later.
See you, sir. Tarun. Sir, Dr. Prashad, sir, I request you humbly to give the closing remarks for this day-long symposium we had. It was wonderful sessions, I think. So I request you to close the session with your erudite remarks, sir.
Okay, thank you. I want to thank all the speakers who gave their time to participate in this fantastic day. I think the day was very long for some of you. I guess Dr. Tapesh Bansal, who has to be congratulated for organizing this. Maybe you did spend the whole day with the group, and I think again, congratulations. I'm sure there will be many people who will want to look at the recordings after that. So I think that they contacting you and your group, the Young in India Intensivist team, will help with that. Um, I I I think the topic of mechanical ventilation is really a fantastic one for two reasons. One is that we are dealing with a technique which is life-saving and which is probably the most frequent technique we use in the ICU. It almost defines intensive care unit. It's mechanical ventilation, so it's really very important to try to optimize the way you use it. But the second reason is that the everything around mechanical ventilation and monitoring is an open window to the patient. And for instance, we have shown that by measuring mechanics, you better understand the pathology of your patient. By measuring respiratory effort, and we have now different techniques, you can understand again the process of breathing by itself and what are the limitations and how it can be managed. So it's really important for everybody to understand that there are two sides to mechanical ventilation. One is the treatment by itself, that of course you need to optimize, but the other one is the monitoring technique, which offers so much information from about your patient, and you will be, I think, a better doctor by just understanding the information from the mechanical ventilator, by interpreting those as a marker of the severity of lung injury, the capacity of the respiratory muscle, and the best time to separate the patient from ventilation, which is also a key issue. And I think it was very nice to have also opening on different kind of patients, because there is not one single patient and one single disease. And the last presentation on brain injury, for instance, was really important because, as mentioned by our chair, the brain is certainly the most important organ which we want to preserve, and there is so much brain-lung connection, which again makes management of ventilation important. So I don't want to again summarize what I've been said, but please go back to the recordings for everything you need. And again, a fantastic congratulations to Dr. Tapesh Bansal for the organization of this very long day, this International Mechanical Ventilation Day. And I'm sure there will be more in the future. Thank you very much, everybody. Tapesh, maybe the final word?
Thank you, Professor. Thank you very much from my side, from my Young India Intensivist Forum, and from all the viewers from across the world who joined in large numbers, who have got educated. Thank you for supporting us, encouraging us, and mentoring us, sir. Thank you very much. And I'll put up the videos as soon as I can, sir. Thank you very much, sir.
Thank you, everybody. Bye.
Bye, everybody. Good night. Have a good day, sir. Have a good day, everybody. Bye.
Thank you.